Um, I just wanted to welcome everyone who signed on this Wednesday night. For those who don't know me, I'm Dr. David Sullivan, an infectious disease doctor and malariologist at Johns Hopkins. I've been one of the leaders in this successful outpatient plasma trial, working on both early treatment to prevent hospitalizations and also infection prevention. I want to start off just thanking you for your courage to join a trial and participate in the research. You're all heroes in my book. We had wanted to just, for those interested, walk through aspects of the trial, give you a chance to ask any questions. And so we have lineup of Dr. Sonia Heath from University of Alabama, Birmingham, Dr. Arthur Shenoy from MedStar Washington, and Dr. Adam Levine from Rhode Island. We're going to talk through the results of the trial. Dr. Turo Casadevall has been a leader an influencer on convalescent plasma throughout the world. He's sort of just going to give his perspectives on the impact of the trial. And Dr. Kelly Gibo is here at Johns Hopkins, is going to close this out.
Next, I will hand it over to Drs. Heath, Shenoy, and Levine for an overview of the trial and the results.
Thank you so much. Well, we just want to begin with a little bit of an introduction, and we spoke to many of these trial participants that are on the phone today and who enrolled in these trials, but mostly when you were quite ill with COVID. So as a reminder, plasma is mostly water. It's the liquid portion of blood. And importantly, about 3.5% of plasma are specialized proteins called globulins, and antibodies are present in our plasma. And these are important for clearing a number of infections, including viruses. And so we know that in somebody who has been infected with a bacteria or a virus and has immunity to that, that we can actually transfer that to another person through a plasma transfusion. Next slide. So there's a lot of data to suggest that antibodies work against SARS-CoV-2. Probably most of you on this call have had at least one, if not multiple, vaccines to help prevent you from getting COVID or having very severe COVID illness. And oftentimes that vaccine is actually inducing or creating an antibody response in you so that you have an early aggressive response to the virus if you are exposed. We also know that there are many treatments that exist for COVID, for SARS-CoV-2, and many of you may have heard of these monoclonal antibodies. I'm not going to go through the list here, but you see 4 kind of flavors of monoclonal antibodies, starting from this bamlanivimab all the way to this bottom one, which is mostly used for prevention. Interestingly, monoclonal antibodies have a specificity of only one specific portion of the virus and a very specific portion of that protein. Given this, the virus can actually escape these monoclonal antibodies and over time not work as well. Some of you may have received monoclonal antibodies at some point or may have had family members that received antibodies. And later in time, if you had another friend or family member that received monoclonal antibodies, it may have been a different named antibody, partly because of the changes in the virus and the need for our treatments to change. Convalescent plasma is unique in that it actually has polyclonal antibody. And the way I like to compare this is these pictures with these jelly beans. In this picture, kind of in the middle of the slide, you see that in any given jar, there's only one color antibody. So for monoclonal antibodies like bamlanivimab, Maybe it's only the red jelly bean color there. There's only one antibody that recognizes one portion of the virus. For convalescent plasma, we have polyclonal antibody. So if you look at this picture in the bottom right-hand corner, you see this array of colored jelly beans, meaning that the antibodies in plasma that are transferred from one patient to another patient probably has many different types of antibodies, many different specificities that allow it to target the virus. And this has some particular advantages, which I think we'll cover a little bit later in this talk. But just to introduce this concept of the difference between monoclonal versus polyclonal is important as we learn from the results of this trial. Next slide. So I mentioned before these different monoclonal antibodies, and one of the things that the CDC and others have tried to do is to very closely monitor what the circulating virus is in our community. So in the early part of the epidemic, we were naming the viruses certain things. Later, we named them, for example, Delta. The Delta variant was available or circulating in August, September, October, even into Christmas time. And then quickly, we changed to the Omicron variant. And what happens with this is that these monoclonal antibodies lose their ability to be an effective treatment as the virus mutates or it shifts in some of these proteins that it might have on its surface. In addition to monoclonal antibodies having this change over time in the virus that makes them less effective, we've had certain times that our monoclonal antibody supply has been very limited. I recall during the Christmas season and the New Year's season, our site would only get 6 vials of sotrovimab, and we would run out in 2 days. And so given this and the need to treat a lot of people across the globe with a virus that is constantly evolving, the question becomes, are there other agents that we can give more of a polyclonal antibody response, like convalescent plasma? Next slide. And so the design of this trial is really the gold standard for clinical trials. And that is a double-blinded, randomized, controlled trial. This means that as a participant, you may have received plasma that came from a person who previously had COVID, or you may have received plasma from somebody who had never had COVID. That way we really could compare the results of these two groups and really try to understand if there was a benefit to this, what we call COVID convalescent plasma. You also recall that you had to have only had infection for 8 or fewer days. And the reason for that is that we believe and increasingly understand that these types of antiviral treatments that bind up the virus with these antibodies work most effectively early in the course of disease. And so that was how this trial was designed, to be used very early in infection, and notably in the outpatient setting. There were some questions that the trial was designed specifically to address. So the primary question was, can COVID convalescent plasma prevent hospitalization when given early in the treatment in the outpatient setting? And then notably, we wanted to determine, were there differences based on a participant's age, race, their sex at birth, other health problems that they may have, their weight, or whether or not they had had COVID vaccination. And so because of the size of this trial and the number of you who participated at these many sites, we were able to address some of these important questions. A secondary question was, can COVID convalescent plasma resolve symptoms faster? And that is being analyzed now. Next slide. And so this is a schematic diagram just to carry you through this. Some of this is repetitive with the prior slide, but if we just go from left to right, we have patients that had previously had COVID and recovered. They then donated their plasma and we were able to test that plasma to determine if it had high levels of antibody against COVID. The specificity here of this, we're not going to get into, but basically a certain cut point was established. And then there were two groups. If you kind of look in the middle of the slide, participants were randomized to either receiving this plasma from people who had previously had COVID or receiving what we call placebo plasma. And what we found that will be gone into more detail in subsequent slides is that we did actually see a prevention of hospitalization, a decrease in the number of patients that were hospitalized if they received this type of treatment. And I'll leave further details for that to subsequent presenters. Next slide.
So we thought it would be interesting for all of you to know who were the participants in this trial, and how much did they look like you? So there were approximately 1,200 people in this trial, and they were fairly evenly split between those who got control plasma, so not the convalescent plasma, but just plasma from donors that might not have had COVID. And as you can see, the age group between the people that got control plasma and the people that got convalescent plasma was fairly equal. And if you look at the sex distribution, it was also fairly equal between the two groups, certainly, and slightly more females than males in general. And of the people that were in the trial, they were predominantly white. About 80% were white. And then the last part, the BMI, just goes to weight, and that's probably less important to talk about. Next slide. And for the most part, most patients were not vaccinated. About 80%, and that's in both groups, were unvaccinated. The vital signs just kind of help us understand how symptomatic were these patients. And so, when they're very symptomatic, they might have a higher pulse or heart rate, a lower oxygen saturation from the COVID pneumonia, and they might have a temperature or a fever. And for the most part, patients did not have those symptoms. For the most part, they had normal heart rates, did not have low oxygen, and did not have fevers. The next couple of laboratory markers help us understand how much inflammation was going on. So a CRP is a marker of inflammation. How inflamed is the body? How perturbed is the body? And for the most part, about 75% of patients did not have a lot of inflammation. So they were not some of the sicker patients. The AST and ALT are markers of the liver, and those can also be abnormal when people are very sick. And for the most part, they were normal. About 80% of patients had these values being normal. Next slide, please. And just so you can kind of see, if you remember back to that time, what your symptoms were and what kind of the symptom representation was of all of our participants. So being tired, having a cough were probably the two biggest symptoms that we saw. And then after that, headache, having muscle aches, and then just having a disruption, so not being able to smell and taste, were probably the next bigger symptoms. And I'll let you look at that for a second. But again, mostly patients had just a lot of tiredness and cough. Next slide. So this is just so that you can see some of our safety data. So in the patients that received plasma, either control plasma or the convalescent plasma, and you can see these numbers are slightly bigger in these two groups, and it just shows that some patients, particularly the ones that were a little heavier may have gotten 2 units of plasma rather than 1. Most of them had no issues with the plasma. They tolerated it very well. And for the most part, we did not see hospitalizations due to plasma or severe reactions at all. And so our plasma in general was very well tolerated. Next slide.
Thank you, everyone. My name is Adam Levine. I'm from Rhode Island Hospital here in Rhode Island, and pleased to present to you some of the primary results from the study. So I think this slide here shows, essentially what are the main results of the trial. You have a graph that shows 2 different groups. Those in blue are the ones among you who got convalescent plasma. Those in red are the ones among you who got control plasma, or our placebo group. And you can see, starting from the time of transfusion, which is day 0, we look at how many people were hospitalized, or what was the proportion of patients who were hospitalized on every day after transfusion with either convalescent plasma or with the placebo plasma. And starting at about day 1 or 2, you can see that these 2 lines begin to diverge. And the patients who got the placebo plasma are hospitalized at a much higher rate than patients who got the control plasma. And by day 10, in fact, most all of the patients who were hospitalized within about 10 days after the transfusion. By day 10, you can see that half as many people in the convalescent plasma group are hospitalized compared to those in the control plasma or placebo plasma group. Overall, about 6% of all the patients in the control plasma group were hospitalized, compared to about 3% of the patients in the convalescent plasma group. Next slide. We had very few deaths overall in the study, thankfully. There were 3 deaths that occurred in patients who were enrolled. And all of those happened in the patients who received the control plasma. There were no deaths in the convalescent plasma group, though I do have to say that those numbers are small, and we can't say, statistically speaking, that convalescent plasma reduced mortality or reduced death. However, one thing that's very clear when you look at the COVID-19 hospitalizations, including the ones that required supplemental oxygen, so patients who had to get oxygen in the hospital, and those that were hospitalized but didn't require oxygen, you can see that the numbers receiving control plasma who were hospitalized are much higher than the numbers for those who received convalescent plasma, again, about twice as high. And that is highly statistically significant. Essentially, according to our calculations, there is less than a 1% chance that this difference occurred by chance. And so it's very, very likely that the convalescent plasma did in fact reduce hospitalizations in patients with COVID-19. There was a question in the chat. All of the patients enrolled in our study were outpatients, which means that they were not yet hospitalized. And that's one of the things that differentiates our study from other studies of convalescent plasma, where they attempted to give plasma to patients who are already hospitalized. In our case, every patient who was enrolled in our study was enrolled and transfused before they required hospitalization. Next slide. So overall, we can see that convalescent plasma reduced hospitalizations by about 50%, as I mentioned. But one of the questions might be, was this different in different subgroups of people? And overall, we see that it really wasn't different in different subgroups of people. Whether you were male or female, hospitalizations were reduced by about 50%. And whether you were young, in your 30s or 40s versus being older, you still had about a 50% reduction in hospitalization. Similarly, both people who were obese and not obese, patients with diabetes, patients with high blood pressure, also saw about a 50% reduction. One thing that was clear, though, is that the timing of transfusion did turn out to be important. So patients who received their transfusion within 5 days of the onset of their symptoms, so patients who were enrolled in the study really early within the first 5 days after their symptoms began, they saw a much higher drop in hospitalization. Patients who were enrolled within the first 5 days had about an 80% decrease in hospitalization, which is comparable, in fact, to all of the other treatments on the market for early COVID, like Paxlovid and the monoclonal antibodies. However, those in our study who got transfused more than 5 days, so either on day 6, 7, or 8, they did not appear to have a reduction in hospitalizations. And it's about the same number in that group being hospitalized who received the control plasma as the convalescent plasma. And so this is an important lesson that convalescent plasma, similar to some of the other treatments out there like Paxlovid, works best when it's given early, within the first 5 days or so of developing symptoms. Next slide. As mentioned, one of the secondary objectives of the study was to see whether convalescent plasma reduced the more minor symptoms that people had that may not have led to hospitalization, but certainly were troublesome for folks. And we actually did not see that convalescent plasma significantly reduced those minor symptoms. So it didn't speed up the time from when your symptoms began to when your symptoms ended. These data that I'm showing here are sort of any symptom, so it combines together all the different symptoms people had, like cough and fatigue and fever, et cetera. But even when we look at it by specific symptoms, we didn't see that any specific symptom either dropped significantly in the convalescent plasma group. Next slide. So the conclusions of our study are that convalescent plasma works when given early. And so it works by reducing hospitalizations, which means that it works to reduce the likelihood that patients who are already infected with COVID will have severe disease, and makes it more likely that they'll just have a minor course of illness. And this is really important because we know that many subgroups of patients, especially like older patients, those who are obese, those with chronic medical problems, are at pretty high risk for having more severe disease, especially if they're unvaccinated. And so being able to reduce that by 50%, as we saw overall in our study, is a significant achievement. And in fact, this is the first trial to be able to show that convalescent plasma can accomplish this. As I mentioned a little bit earlier, the prior trials of convalescent plasma that you may have heard about in the news were all done in patients who already were hospitalized. And what's clear is by the time patients have already developed severe disease, it's too late for convalescent plasma. It's too late for treatments that neutralize the virus, because by the time they're hospitalized, it's not the virus replicating in their body that's causing them the problem. It's the inflammation that their body has developed in response to the virus infection. And so if you want to neutralize the virus to prevent that inflammation from developing in the first place, the treatment needs to be given early, ideally within those first 5 days of symptoms. We also saw that convalescent plasma, as I mentioned, did not change the prevalence of symptoms, but that was, again, more of a minor sort of secondary issue that we were looking at. And most of the other treatments on the market that are available also primarily were shown to reduce severe disease like hospitalization, not specifically symptoms. I do want to point out, as was mentioned, that one of the differences between convalescent plasma and these other treatments is that it is polyclonal, which means that it will evolve with the virus. And so as new mutations, as new variants of the virus evolve, in theory, the convalescent plasma people develop in response to those variants should be effective at treating those future variants. unlike the monoclonal antibodies, which may become ineffective at treating future variants of the disease. Even more importantly for the rest of the world, and I do a lot of my research and work in the global south and sub-Saharan Africa and South Asia, most of the treatments that we have here in the US, such as Paxlovid and monoclonal antibodies, are unaffordable in most developing regions of the world, and people even today don't have access to them. But convalescent plasma is very cheap, and it's available everywhere in the world that people have infections with COVID. And so it's an option that can be used in lower resource settings, especially that don't have access to the other more expensive treatments that are under patent that we have here. Convalescent plasma is not patentable, and so it is available everywhere in the world as needed. A couple points that should be made is that we don't know if you combine convalescent plasma with another treatment like Paxlovid, if it will work even better than either of them alone. And we need future studies to see if the combination of convalescent plasma with other available treatments might be effective at reducing hospitalizations even more. Next slide.
Thank you, Dr. Levine. This is your last slide. And as we transition to our next presentation, I just want to let everyone know that I've put a PDF of these slides in the chat if you would like to save that so you can look at these numbers and graphs later on.
For those who came late, just again wanted to thank everyone for their courage and persistence in joining the trial. And as Adam said, helping us to show that it works in the outpatient to prevent people from going to the hospital in the first place. we're going to turn it over to Arturo Casadoval, who's going to share with us his perspectives on the impact of this trial during the pandemic. Thanks, Arturo.
Thank you, David. I don't have slides. I just plan to talk about it. So when you think back to the terrible days of the spring of 2020, there was no therapy. The only thing that people had was supportive care. They had oxygen. And in the United States and in many countries, the only potentially available therapy was convalescent plasma. And many countries set out to test it. And it's natural that because the people who were dying in great need, that you wanted to know whether it made a difference in those who were seriously sick. This was, in retrospect, didn't really make a lot of sense, although it was an important question to answer. So when you heard on the news, as Adam pointed out, that convalescent plasma, some people say, did not work. The reason was it was used very late. The pathogenesis of COVID has two phases. First, we tend to have a viral phase. And this viral phase, if it progresses, triggers inflammation. And it is the inflammation that puts you in the hospital. Inflammation in the lung that interferes with the ability to breathe. So convalescent plasma, like Paxlovid, like the monoclonal antibodies, is an antiviral. It's going to work early, in the early phase of disease. So when you give it early, it kind of neutralizes the virus and reduces the likelihood that the patient progresses. And this is what you have heard today, that when given early, the likelihood of somebody progressing to be hospitalized was reduced by 50%. And the earlier you used it, the more likely it was to work. And now you can begin to understand how, if it is used late, one is not going to see much of a difference. So in contrast to all those trials, the Hopkins trials was different in that from the very beginning, a decision was made to test it as an outpatient. This was an enormous logistical undertaking. Think about it. You talking about infected individuals. Where are you going to bring them? Where are you going to infuse them? Well, a lot of issues had to be worked out. And by the time that this began in earnest in the summer of 2020, it took a while to accrue the number of patients, the number of you who participated, which allowed the trial to be so significant. The information was first available by November of 2021. And then it took a few weeks before all the information was put together. And what Hopkins did was it took the unusual step of having a press conference. And the reason we don't like to have press conferences, we like to have the work be peer reviewed. But before one goes out, but you recognize that peer review takes often months. And what we needed to do is to try to get this information out. So what was done was to get all the data and to put it in a way that was available to the press, to other doctors in the forms of a preprint. And a news conference was held in December 21st. And to give you a sense of how that news conference changed things, within a week, the Food and Drug Administration allowed the use of convalescent plasma in outpatients. They basically allowed the movement into the outpatient space. Within 2 months, two learned societies, the Infectious Disease Society of America and the AABB, used to be the American Association of Blood Bankers, now it's the American Association for Blood Biotherapies, issued recommendations supporting the use of convalescent plasma. Now, by that time, because we had antivirals and because there have been this sense that it wasn't as effective, plasma was not being collected. But by March 7th, the Red Cross began collecting plasma again. And what has happened in the past few months is the realization that one of the great problems that we're facing today is that the immunosuppressed, often when they get disease, COVID, it becomes chronic, it becomes very difficult to treat. So convalescent plasma has emerged as a therapy of choice. As pointed out early, these individuals who are immunosuppressed often have a lot of virus. And when you use a monoclonal on them, there's a high likelihood of selecting a resistant drug. We have also lost almost all the monoclonal antibodies. We have one left, and everybody feels that with continued viral evolution, it will be lost. So you participated in a historic trial. This is a trial that teaches humanity how to use convalescent plasma. A legacy of the COVID calamity is that when we face future calamities in the future, and again, we find ourselves with no therapies, no drugs, because it takes time to develop them, convalescent plasma will be there. And instead of using it in individuals who are very sick, this trial teaches you that what you need to do is you need to set up the facilities to treat those at risk early. And I think this is a tremendous legacy going forward, because one of the things that we worry as scientists and physicians is that the great threats that are out there, for example, think about the enormous disruption that was caused by COVID to our society. And that's a disease with a mortality of 1%. Some of the other coronaviruses have mortality of 5 to 10%. When you begin to get to that level, society collapses. Police doesn't show into work. Bird flu is another big threat out there. Mortality as much as 50%. So imagine we're gonna be facing these threats in the future. When we face these threats again, there will be people who recover, and those people will have convalescent plasma, and we will be able to use it much more effectively at that time, until antivirals, until monoclonals are developed for those agents. So I think that all of us that have been involved in this, whether we participated as physicians, whether we participated as patients, whether we participated, the enormous administrative commitment that was needed to maintain this and to run it, need to feel that we were part of something historic, and that the great legacy is that this information is now part of human knowledge. And not only is helping us on dealing with the new challenges of the pandemic, that is the immunosuppressed, the new variants of concern, but it is also knowledge that will, in the future, could be of tremendous help for all types of societies. So that is pretty much what I had to say, David.
Thank you,
Dr.
Arturo. Thank you, Arturo. So we do have time for questions from people if they have, yeah, if there's. I think you can either type them in the chat or raise your hand, and Cecilia can unmute you.
I do see we have a hand raised. You should be able to unmute.
Right. Can you hear me?
Yes, sir.
All right. Hi. Hi. Thank you very much. And I learned a lot today about what you did, and I was glad to be part of it. So I think that this will be, as was told, that this will be a great therapy, especially in the developing world. And you know, what's the status? What do you think? Are the folks in the developing world, they are embracing it, or you know, how are things going? Or maybe I was thinking that, you know, even with us, people who participated, maybe you can create some videos and probably share that with the patient, and we can share our experience, and that might be something interesting. Thank you very much. And I'm going to mute myself.
Thank you. I'll let Adam comment a little bit more on the global perspective, or possibly Arturo. I think this takes time. We are working with the WHO. They had made a decision on December 7th, 2021, that said that they didn't think that the benefit outweighed the trouble of getting convalescent plasma. We disagree. We know it is effective, almost as good as the monoclonal antibodies. And I think, so we're still working to implement it. And as we know, coronavirus is here to stay, and we're still going to have some other waves. And just got a communication from a doctor in sub-Saharan Africa about a higher mortality rate of pregnant women with SARS-CoV-2 in the hospital in sub-Saharan Africa. So it is real. It is something that we would that we still are working to implement. Adam or Arturo?
Let Adam go first.
Yeah, so, you know, as was mentioned, I think this is a therapy that can be very effective in low and middle income countries. And I think we are starting to see its use in some of those settings, but most ministries of health in low and middle income countries really set their policies based on WHO. And so right now we're actively working with WHO to get a recommendation for the use of convalescent plasma in the outpatient setting. As was said, it is unfortunate that, you know, based on the earlier trials that were done in hospitalized patients, WHO made a determination not to recommend convalescent plasma literally just, you know, weeks before we announced our results. And so now with the results of our trial and also some other trials coming out soon, we are hopeful that WHO will change their opinion, and then I think that will open up many ministries of health in low and middle income countries to start recommending and providing convalescent plasma as treatment. And pass it on to you, Arturo.
So I want to second what Adam said. It is, as you know, many countries just don't have a lot of resources, and they set their policies based on what the WHO says. And it is unfortunate that they came out with a strong recommendation against it without seeing our data. David presented our data to them in December. We have an article in the British Medical Journal arguing that they need to reconsider it in February. In April, we organized a letter that was signed by over 200 physicians from 15 countries, asking them to change the recommendations. It is now 7 months later, and they haven't changed them. I'm told that, like a lot of this has to do with the way these organizations work. They tend to work slowly. However, I feel that this situation, we're dealing with an emergency, and that they need to move faster. And I'm told they're aware of it. They certainly got our letter, and I torture them by social media once a month to make the point. But this is, in my mind, look, this therapy, because it has no patent, it has no profit, it is a public good. People donate, and it's available in every country in the world. And most countries are not going to have Paxlovid. Most countries are not going to have monoclonal antibodies, but they have convalescent plasma. I can tell you that some health ministries, for example, in South America, have made it available based on the Hopkins data. I can tell you that in Asia, some countries like Indonesia are using it, but many are not. And we need to continue to work with WHO to change the recommendations.
Was asking about how long the monoclonal antibodies last. The monoclonals last for 3 weeks, sometimes longer. There's one Evusheld that was designed to last almost 2 months. The polyclonals, we think, have a little shorter half-life. It could be from the dose that we give isn't as high as with the monoclonals. So they last for a week or two on the polyclonals. I also saw a question about informed opinion regarding continued mask wearing with the ongoing pandemic. And I think all of us agree that the that the pandemic is ongoing, and we still need to address it with convalescent plasma and with masks. I think it's we just have to be prudent if we're in crowds, if there's people that might or working with the public in audiences, planes, transportation, that yes, we should wear masks. And in the beginning, that's what healthcare workers had. We had a mask and a shield, and it worked. So, I mean, I started in June, and I think with the mask, knock on a bunch of wood, and still have not gotten COVID yet. It doesn't, well, that means I'll get it next week, right?
We hope not. See, we have someone else raising their hand.
James Paxton.
Hello, can you hear me?
Yes.
Yes.
Thank you. I think this is a great opportunity for me to share my story. So I'm actually an emergency physician. I work in Detroit, and I'm also a clinical researcher. And I was very excited to join the trial very early. And I can say I actually contracted COVID during the study and was able to participate as a subject in the trial. And to me, and I've been in emergency medicine for 15 years as an attending physician. I've participated in many, many, many clinical trials, various topics, various conditions, but I can tell you that this trial means a lot to me personally, not just because I had COVID and because I decided to become a subject in this study, but because I see the value of this, not just for the COVID-19 pandemic, which is still ongoing, but hopefully improving in some parts of the world, but also because I see the value of what we're doing here in the future. And that when future pandemics happen, the data that we collected, the information that we have gained from this study is going to mean a lot to investigators. And I think I'm going to say just selfishly to clinicians treating patients in the emergency department, which I do every day. I saw people in all states, in all conditions from COVID, everyone from a runny nose to unfortunately dying from COVID. And this study means more to me than most of the studies that I've been involved in because of the significance, not only of the condition, but also of the way that it was run and the results that we have, which demonstrate a clear benefit. And I'm so excited and so proud to be part of this study. And I'm speaking as a physician, but also as a subject, also as a person. And I just want to speak out to the members of the team, the research, all of the research members that are on this call, and just say thank you for what you're doing, because it means a lot to everybody. And I don't know if everybody in the study understands the significance of what they've done, but this is the kind of thing that makes your contribution so important, not just now, but also in the future. And I'm very proud to be part of this study. I just want to say that. And this is as a person, not just as a doctor, but I just think this is something that I'm going to be proud of the rest of my life, that I was involved in this study.
Thank you.
To say, I think there was one other person that wanted to be unmuted.
Yes, you should be able to unmute now.
Can you hear me?
Yes.
Okay, so Dr. Paxton, hearing him speak gave me the courage to pipe up. I am also in Detroit, and I stumbled into the study. I had been diagnosed with COVID like literally 2 days before and was very ill. And my daughter saw a blurb on social media about a news report that had talked about it. And she said, we need to enroll you in this. And then she enrolled in the part for people who didn't have COVID. So we both went. And I was sick as a dog. I drove myself because we didn't want to be in the car together. I didn't want to expose her because she didn't have COVID. I don't even know how I made it to downtown Detroit. I mean, literally, I was so sick. It was the best thing I ever did. The care that I got at DMC, I don't know if that's where Dr. Paxton is, but the nurses there that were from Wayne State University were amazing. I wouldn't have gotten seen by a doctor because back then I had it in November of 2020. I slept through the whole presidential election, which I worked hard for. Anyway, so because of the study, I mean, back then it was like you couldn't go to the doctor. You didn't go to the hospital unless you were really, really sick, which I was reluctant to. So because of the study, the head of the emergency room came and listened to my lungs, checked me. I felt like, okay, at least I know I'm going to live. I had no idea. So it was awesome. And I didn't really understand how important it was either. So I feel really proud to have been part of this. And I joined in late, but I'm glad I at least got to hear part of it and realize that for me personally, it was of great benefit because I feel like I got medical care that I wouldn't have gotten. And eventually my daughter ended up, and they tested her for COVID every time she went. And then eventually she got it too. But so I found out, am I allowed to say this? I found out I was in the group that did get the plasma. And I credit that with, maybe that's why I even though I was really sick, I didn't have any respiratory problems and I'd had pneumonia, so I was concerned. So I credit now, now knowing this, I wonder how much that having received the actual plasma helped me get over COVID and not have the side effects that I would have had. So it was a good thing for mankind and a great thing for me personally. So thank you all very much.
This is James Paxton. Can I say something else?
Yes.
I just want to respond to that. I mean, I actually had COVID around the same time, so we're like COVID buddies.
Oh, awesome.
And I can say that, I really think that this pandemic has brought out a lot of things about society, about humanity.
Oh, yeah.
And I feel that what it boils down to, in my opinion, is it's fear. It's fear, it's anxiety. And knowing that there's something that you can do to address the problem is amazingly helpful, not just physically, but also psychologically. And I don't know if anyone's ever going to talk about this or write about this, the psychological benefit of knowing that you have the opportunity to participate in treatment like this. But I think that's huge. Knowing that you can do something, right? We feel helpless. COVID, I think, has made many of us feel helpless about the situation, about our physical condition, about the virus, about the pandemic. And knowing that something like this trial exists and knowing that we can participate and not only improve perhaps our own physical condition, but also benefit people in the future is so
Empowering.
Yeah, thank you. It's so empowering. And I don't know if anyone's ever going to talk about this. I don't know if anyone's ever going to make this a point of discussion, but I feel that this type of trial, which was so well run by the folks at Johns Hopkins and all of the sites, and I'm proud to say that Wayne State University was the only local site that participated in this trial. And I'm proud of that.
And they were great. Awesome.
That we did that. Yeah, I thank you so much, because, and I'm going to pass it on to the team.
Oh, yeah.
I feel like this was really a chance to do something important, because when you get down to it, when we talk about convalescent plasma, you're talking about people helping people.
Right.
And this is something that we don't get to do. Even as doctors, we don't get to do that very often. Humans helping humans. And this is the essential part of convalescent plasma, is a person who has experienced and dealt with and lived with an infection that might be life-threatening can reach back and actually do something to help someone else. What else? I don't know of any other study that I've ever been involved with, and I've been involved with a lot of studies, where I feel that subjects, participants, people have a chance to actually help not just themselves, but other people directly with their participation in the study. It's an amazing thing. And I am so honored and so blessed to be involved. And I'm sorry to take up more time, but I thank you for sharing your story.
James, I'm glad you brought that up, because in the dark days of the pandemic, when nothing could be done, the country mobilized. And within a year, 500,000 people have been treated. And even though convalescent plasma was maligned subsequently by the trials, it is important to realize that the randomized controlled trials done in the United States all showed a reduction in mortality. The American doctors were using it right. They were using it on admission, very different than recovery. And we were able to document by looking at epidemiological data that the more plasma was used, the lower the mortality per week, and estimated that about 100,000 lives were saved by this effort. And that's published, and that's out there in the public record. But the point is that when there was nothing, the sense that you could do something provided a lot of hope. And people mobilized, people went out there and donated plasma, the country organized, and this is a great story that's hidden in all the foibles of this pandemic. So I'm glad you brought that up. And I think we, as we move on and we begin to take stock, I think that this whole effort will be celebrated.
I'm Kelly Gibo. I'm infectious disease professor at Johns Hopkins and have had the pleasure of working with David and Arturo and others across the country on this important study. And I know we're at the end of the hour, but just wanted to take a moment to thank all of you for your incredible bravery and coming to both receive and donate plasma for those who donated during a really challenging time. And we've heard a story today from several of our participants who came or drove through sites that may have been outside, who received plasma when they were really not feeling well. They came to follow-up visits, donated their specimens, donated their time, and were very gracious, which allowed us to be able to understand when is the best time to use plasma and how it can best be used as a further treatment. So we are incredibly grateful to the funders who helped us with this, to the staff who was incredibly brave and dealt with uncertainty when we weren't sure how to protect ourselves. There was a large part of the study that was done when vaccines were not available. And to you, our very generous participants who've donated their time, their biospecimens, and their incredible bravery to helping make this happen. We, as Arturo and others have said, have benefited from this, and we believe that future generations will as well. The other thing that we have learned from this is how to conduct a study. And during a pandemic, many of you went to treatment sites that were unusual. You received care in a place that was different from where you would usually receive care, whether that was in a tent or in an annex of a hospital, and you were willing to do it. And we had staff who were willing to figure out how to do consent through Ziploc bags and online and a variety of other creative ways. And that's all worked. And so that we have made progress in being able to do research, both for COVID as well as for future pandemics. And so we're incredibly grateful for your time. I just checking to make sure there's no other questions in the chat. Cecilia, is there anybody else that we need to acknowledge here?
Yes, there's one question asking, it reads, I noticed that the participation of African Americans and Hispanics was low. Knowing the background history on clinical trials with these populations and the low participation in this study, what would be your approach or strategies to invite them or to increase their participation to be part of future studies such as this successful one?
I'll start out with the Hopkins answer to this. This was something that was very important to us to achieve diversity in this study. And we relied on a number of different organizations to help us with publicizing our study, as well as trying to use community ambassadors. So we had a number of our participants who came from communities of color and went back to those communities to help us advertise our study. We also tried to recruit from those communities to try to make sure that we were being inclusive. And this includes both people of color, but other groups that potentially weren't included in studies previously, whether those were LGBTQ studies or rural participants, trying to make sure that everybody had access. I know that each site approached this a little bit differently, and so I'll open it up to our other panelists to discuss how they did it at their sites. But I think the ultimate goal is to achieve diversity in research, and it's an incredibly important thing that we continue to strive for, and I appreciate the question. Sonia, would you like to say what you guys did in Alabama?
Yeah, similarly, we actually had a testing site at our university, and we tried to give equal access to this trial to everybody who tested at our university. But then in addition, we tried various efforts in the community, recruiting through radio talk shows that would be sort of a question answer interview type format, various TV formats. And I think that probably the thing that made the biggest difference was just one brave person coming out and participating in the trial, and then them talking about their positive experience, just like, two other participants have done on this call today. And I think, whether you were in the placebo arm or the treatment arm of the trial, hopefully everybody was treated with respect and, with care from the nurses and the whole study team. And I think even those calls on day 3 or check-ins on, subsequent days of the trial, and just knowing that you had somebody to talk to if you were concerned about new symptoms. And I think over time, certainly here in the South, there's concern about participating in clinical trials from different communities. But I think over time, Effective trials like this one can build trust in various communities and hopefully help us gain equity in representation for all groups in clinical trials, because that's very important, whether it's men and women, Black, Hispanic, Caucasian, various communities all need to be represented in these trials. So thank you for the question. It's really an important one.
Yeah. I'll add that I thought this trial did a really great job actually of working to recruit a diverse range of participants. The African-American population in the trial was about 14%, which is actually higher than the African-American population in the US, which is around 13%. The Hispanic population was a little bit lower at 15% than nationally, where it's about 18%. But I think a lot of that actually has to do too with lack of access to primary care, because for an outpatient trial, many of the people are referred to our study by primary care doctors. In Rhode Island, what we really worked to do was use Spanish language radio, especially to get the word about our study out to those communities, so that those who were infected with COVID but maybe didn't have a primary care doctor or someone to refer them to our study could at least hear about it and call our number and sign up themselves.
So this is Shmuel. I got unmuted. So and thank you. I think that one of the things that we've talked about very early on is the best time to plant the tree was 20 years ago. The second best time is now. So it would have been good if us as researchers and the research enterprise in America had built the confidence generations ago, but we were working on what we can do during the study and today. And one of the examples that we did, and there's a program that an amazing guy named Panagis Galatsiatsos, I'm sure I'm messing up his Greek name, runs in Baltimore, where he works with church leaders and other religious leaders and community leaders in Baltimore to advance medical issues and communication between Hopkins, the academic site, and the community of Baltimore. So he invited me to also speak and talk with the religious leaders to explain what we were doing, that yes, we were experimenting on people, but we weren't experimenting on people. So it was, but I think that like so many other things of this study, this is not a one and done deal. We need to continue to build those relations.
Thank you, Shmuel. Thank you all. And again, to the participants, thank you for your courage and trust in us, and glad to be part of showing that outpatient convalescent plasma works. Good night.